So Tri-State Connect was developed for to serve people anywhere they happen to be at this moment, the third Tuesday of the month at 2 o'clock. You can tune in from your laptop, your tablet, or call us on the phone and listen in to speakers that have knowledge of the care and treatment for scleroderma patients. Our guest speaker today is Jessica Farrell. She will be talking about the medications that are prescribed for scleroderma and how to talk to and have a good relationship with your pharmacist. So the Tri-State mission, this program, as well as our other support groups, fulfill the Tri-State mission by providing education and emotional support to people with scleroderma and their families. We stimulate research and support research designed to identify the cause and cure for scleroderma. And we also educate the public and try to raise awareness of this disease. I'm Mary Beth Bovic-Cadillac. I am the Director of Patient Education and Support. Jan Nitty is the support group leader for this group, online group, and since Jan had to have some surgery, I'm taking over the meeting for her, and I'm happy to do so. So let me introduce Jessica a little bit. Jessica received her Doctor of Pharmacy degree at Albany College of Pharmacy and Health Sciences in Albany, New York. She is an associate professor in the Department of Pharmacy Practice at Albany College of Pharmacy and Health Sciences. Her clinical practice is with the Center for Rheumatology in Albany, New York, and she works as a clinical pharmacist at the center. She also serves as co-director for the Steffens Scleroderma Center in Albany, New York, where our friend Dr. Lee Shapiro works, and it is one of the treatment centers in the group of treatment centers that we have throughout the country. Jessica has, she's served with several professional organizations, the American College of Rheumatology, Association for Rheumatology Healthcare Professionals, American Society of Health System Pharmacists. So she's a busy girl, and we are very happy that she's been able to carve out an hour for this activity, and I'd like to welcome her to take over the presentation, and her topic is current medications prescribed for scleroderma. Please welcome Jessica Farrell.
All right, thank you, Mary Beth, very much. So I'm just going to, so if you can, yes, thank you. And I will share my slides. So, let's see here. So I'm not sure if there's a way, I think there is a way, there's a chat function for those who are on the webinar. So I keep that open. So if there are questions that come up, please feel free to use the chat option. I have my, are you able to see my slides now?
Yes.
Okay. So if everyone, all the attendees, generally it helps prevent feedback if the attendees keep their mics muted. So Mary Beth, you have yours on and I have mine on, which seems to sound okay. If people join, we might just want to ask them to mute their mic, and then we can, if you want to keep an eye on the chat section, and feel free to interrupt me, and I will be happy to address questions. So I had developed this this presentation quite a few years ago because I thought it was helpful for patients to be educated on how some medications that maybe aren't used to treat their disease that can be avoided that might make their disease worse. Also a little bit of background on an overview of all different medications, which I won't go in great detail because there are so many, there's such a variation in patients with scleroderma in terms of their symptoms and the medications that they require. I'll try to keep it very broad and brief and then focus on questions. But I will talk a little bit about those treatments. And then I really want to focus on how you can get the most out of your relationship with your pharmacist. So as a clinical pharmacist, I have the luxury of having access to a lot of information from my scleroderma patients. So I have access to their medical history, their charts, their medications, conversations that they may have with their rheumatologist, so specifically Dr. Shapiro. I have the luxury of interacting with Dr. Shapiro on a regular basis, so we can brainstorm ways to kind of get over some of the medication-related problems patients are having. But not every patient has that access to a clinical pharmacist. So there are a few tips that I have for you to help enhance maybe your relationship with your community pharmacist, the one that you're seeing on a monthly basis, who might not know a lot about your disease, but I'm sure would be very willing to learn how they can help you more. So we'll talk a little bit about that. So with treatment, obviously we don't just throw drugs at people if they don't have a purpose. We want to make sure that we're choosing treatments that are going to help maintain functional status, ultimately improve quality of life, and in our patients with autoimmune diseases, we really hope that we can find agents that slow the progression of the disease and prevent organ damage. So, we might not have a lot of targeted therapies in scleroderma, but we certainly have some that have been shown to slow the disease progression. So these are kind of our goals of treatment. When your provider decides to start you on therapy, the benefit of the drug should certainly outweigh the risks of the side effects and the side effect profile. And if at any point side effects are becoming a problem and decreasing your quality of life, that's a conversation that you need to have with your provider. So in terms of some non-pharmacologic treatments, so even though I'm a pharmacist, I am a huge proponent for non-drug related therapies. So very briefly, Raynaud. So as it's getting colder out, we might be starting to have patients experience more Raynaud's attacks. So where the fingers are getting white and maybe losing circulation in response to cold. So there are quite a few non-pharmacologic options that can be used to help increase blood flow, keeping blood flow to the digits, the fingers, and coming up with some ways to really try to prevent severe attacks. So, it makes sense. So in the wintertime, dressing warmly. People think, okay, mittens on your hands. Mittens are definitely better than gloves because the warmth from the rest of your fingers touching can help. They have hand warmers, so those little packets that you can put inside your mittens, which is really helpful to keep the fingers warm, especially maybe when driving. We have some patients that put mittens on, they'll put the hand warmer inside their mitten. If they don't have a heated steering wheel, that can really help. Wearing a hat is really important too because we lose a lot of heat through our head. So even though it doesn't really, you don't think that it would make sense to wear a hat that's going to help your Raynaud's and your fingers, we really can. Using things like an electric car starter, so getting your car warm if you don't have a garage to park in. Exercise, so within limitations. So if you're able to exercise, that certainly helps increase blood flow. Avoiding a lot of caffeine and certainly avoiding smoking. So smoking has been shown to worsen many autoimmune diseases and can definitely cause what we call vasoconstriction, or those blood vessels tightening up, especially at the digits. So that's important. Joint pain and stiffness. So I always say it's about moderation and balance. So you need to make sure that if you're able to exercise, it is very good for you, but you shouldn't be pushing yourself to the point where you're feeling that it is hurting, or that you're overdoing it, that's causing you to be really drained and tired the next day. So that's important. But there are lots and lots of benefits to exercise. And just balancing that with rest. And not just physical rest, so emotional rest is really important too. So it is very common for us to see patients that have had an emotional stressful event in their life. So maybe their child moves out of their house and goes away to college. Maybe they have a divorce. Maybe they have a sick family member, a death in the family. And those emotional triggers, those can serve as triggers to disease flares. So it is very important, if you have a lot of stress in your life, to find ways to help reduce that stress and have this emotional rest. If it's mindfulness, mindful meditation, meditation, different meditation techniques have really been helpful in preventing severity of flares and reducing severe flares. Other things, so these are kind of the common things that scleroderma patients, especially newly diagnosed patients, need to learn, is how to avoid making their symptoms worse. So in terms of GI disease, we often say to try to do very small meals, make sure you're chewing really well, cutting up your food really small, avoiding things that can exacerbate the reflux and GI issues that patients with scleroderma have. So those are some techniques there. Lung symptoms, so getting your flu and pneumonia vaccine is important as a preventative measure. Making sure that you're not letting any lung symptoms, so any respiratory issues, kind of not dismissing them, and making sure that your rheumatologist is aware of those. Skin symptoms, so for skin tightness and itchiness, so moisturizing. So the Scleroderma Foundation has lots of resources for different types of moisturizers and skin protectants that is helpful. Avoiding really hot showers and baths and harsh cleansers, so trying to use things that are more like hypoallergenic and really not any much scents or anything with them. Humidifiers are great, especially in the winter time, but it is so important that they are cleaned regularly. So bacteria can grow in water, so humidifiers can, if not cleaned properly or the water not changed regularly, they can grow some bacteria, so we need to be careful about that. And then kidney symptoms. So the kidneys, I think many scleroderma patients, the first thing they learn, at least from Dr. Shapiro, is to carry their scleroderma renal crisis card in their wallet, so that if you were to have some acute changes in blood pressure, need to go to the ER, that the treating provider has access to that scleroderma renal crisis card, so that they are able to treat you appropriately and that they can treat you quickly.
Can I ask a question?
Sure.
What is the scleroderma renal crisis card?
So Mary Beth, the Scleroderma Foundation does have, the Tri-State chapter does endorse that Dr. Shapiro had developed this during his fellowship training as one of his projects. He refers to it as a contribution to the medical community. It is a wallet size, so it basically looks like a business card. And on one side, it talks about scleroderma and the risk of renal crisis. It also has a spot for you to write in your treating rheumatologist's name. It also has information to the provider who is treating you about what type of medication to use. So there's a very specific medication. It's called ACE inhibitor that's given IV, and that has really been shown to prevent any damage and help the patient recover from an acute renal crisis. So if you don't have a copy of that card, Mary Beth, is that something that you can send out, or do you have it on the website?
Yes.
Is this something you carry if you have a kidney problem, or you have to carry, or you should carry it anyway? I don't know what an ACE inhibitor is, but if you're not prescribed that, then you still need to carry it?
Yeah, so if you have scleroderma, or you have systemic disease, and you are at risk for kidney crisis, yes, you should carry it. You may not be on an ACE inhibitor currently, but if you were to develop renal crisis, so if you are at risk, you could ask your rheumatologist. If you are at risk for renal crisis, then yes, you should keep that card in your wallet.
And where do you get that card?
So Mary Beth, are you able to send her one, or?
Yes. Can you hear me?
Yeah, I can.
I wasn't sure if my mic was on again, but yes, we have them in the office, so just let me know if you would like me to send you one. Just send me an email and we'll get them right out for you.
Okay, great. And I have one more question. Sorry about that. you talk about like avoid alcohol, which I don't drink anyway, and caffeine and spicy food, carbonated drinks. Is it if you have the GI symptoms, or if you should avoid it in any case?
Well, so in some patients, Scleroderma, so GI symptoms are many times the first symptoms that patients experience. So some patients have, and generally this isn't in Scleroderma patients, but some patients can have silent reflux, meaning that they have reflux and they have some damages that's happening in their esophagus, but they don't feel it. So that's something that you should certainly talk to your rheumatologist about in terms of whether you have any damage that they're able to identify and whether they think you're at risk for reflux symptoms.
Okay, thank you.
Sure. So general principles to treatment. So unfortunately, there is no single drug therapy that has been found to treat all aspects of Scleroderma. So I don't think that that's ever a possibility because the disease is so complex and that it's unlikely that will ever happen. So we need to treat the different aspects of the disease. So in terms of treatment for each individual patient, which is sometimes hard for me to give these talks because it's hard for me. I don't know your medical history. I have to be very general when I'm talking about treatments because I don't know if it's a good option for all the individuals in the audience. So, but treatment is very, very individualized in Scleroderma, and it's individualized in any disease state, whether it's rheumatoid arthritis or osteoarthritis or Scleroderma. The treatment is not a one-size-fits-all, and that's something that your provider, your treating physician will be looking at all different aspects of you as a patient and making a decision that's the best for your disease. Early treatment and screening in some aspects of Scleroderma has been shown to improve disease outcomes or even prevent disease progression. So that's a very positive thing. So early identification is to slow the progression of the disease is very important. So for pharmacologic treatment options, so here is an overview of all the different types of medication, and this is not even an all-inclusive list. I mean, there are other medications that are sometimes used to treat patients with Scleroderma for some aspect of their disease, but this is kind of the general list. So we have medications that are used for Raynaud's, and I'll go through these, I'll touch on each of these separately, but we have pain medications, we have immunosuppressants, we have pulmonary drugs, and we have drugs for the kidney or for renal crisis. So the next two slides go through, or this slide goes through common medications that are used for Raynaud's phenomenon. And the medications are listed there. There is a wide variety of medications that can be used, and oftentimes it's trial and error. I will say that we generally try to start with the calcium channel blockers, so amlodipine, amphetamine, and we may have to use combination therapy. So if your Raynaud's is not controlled by that, we might have to add on other medications. Ultimately, the biggest thing to know about these drugs is that they are causing vasodilation, meaning that they're opening up the blood vessels in the fingertips and the digits. So that ultimately can lead to some low blood pressure, which can cause dizziness, some headaches. So those are kind of the side effects that we have to be really careful about and make sure patients are aware, because we certainly don't want their blood pressure to go down so much that they're getting dizzy, lightheaded, and falling. So generally we have to go very slow with titrating up and increasing the dose very slowly to prevent some of those side effects. Here are some drugs that are a little bit more specific. They can be used in very, very, very severe Raynaud's, and where ulcers are happening in the fingers or potential, so lack of blood flow to the fingers that could result in an amputation of the digit or another area. So these are kind of what I refer to as bigger guns. And again, these medications are unfortunately not easy to get approved by the insurance companies because they are for Raynaud's, because they are not FDA approved. They're considered off-label, which doesn't mean that they're not safe. It just means that from an insurance perspective, they may not recognize these drugs as being an option for patients. So for our patients. So it sometimes takes a little bit, they're also expensive medications, so it sometimes might take a little bit of back and forth with the insurance company to get them approved. In pulmonary hypertension, we do use some of these medications too because they cause what we call vasodilation, or increase opening up the blood vessels in the lung area also. So patients that have pulmonary hypertension associated with their scleroderma, these are some of the drugs that we can use. Same kind of rules apply. If we're opening up the blood vessels, we're putting, we're dropping the blood pressure and can cause some issues there. So we have to be very careful with them. To avoid, so we talked a little bit about this already, but in terms of drug therapies, so here's a list of medications that essentially what all of these medications are doing is constricting blood vessels. So in patients with Raynaud's, that's the problem. So we want to try to avoid, we don't want to add on anything that can really constrict the blood vessels. One of the over-the-counter products that's common is pseudoephedrine or Sudafed. So you have to be really careful about when you have a cold, if you're buying combination products over the counter, that they don't have these decongestants in them, because they will constrict the blood vessels and exacerbate or start a Raynaud's attack. Let's see, any questions so far? So this one I have to talk very carefully about, because sometimes we don't use NSAIDs at all in certain patients. So they have a lot of concerns with them and have to be used very, very carefully, because they can affect the stomach, they can affect the kidney, and they can, long-term, could potentially affect the cardiovascular system. So it's something that you have to talk very carefully with your treating provider about. If you have swelling in any of your joints, which some of our scleroderma patients do, then they might be a good option for you, but they need to be used very carefully. So I don't usually recommend using over-the-counter NSAIDs like ibuprofen. I think I have a list here, yeah. So here's a list of the over-the-counter. So aspirin's listed here because at high doses, it is an anti-inflammatory. If you're on low dose for cardiovascular protection, like 81 milligrams, then, or 325, that's low for cardiovascular protection, that's safe. But higher doses can lead to some of these concerns to watch for. So probably the most immediate ones are the ones that are bolded. So stomach issues, heartburn, increasing your blood pressure. So I always caution patients to be very careful when they are buying prescription products or over-the-counter products and combination products, because some combination products they can sneak in a couple different drugs, and it can be a little confusing. So there is a couple years ago, maybe it's more than a couple years ago now, the FDA required that on over-the-counter medications, the actual drugs have to be highlighted in yellow. So the active ingredients need to be highlighted in yellow. So if you flip the box over and look at the yellow section, it should show you where all of the drugs that are in that product are. And if you have questions, you can certainly talk to your pharmacist about that and have them help explain that to you. Okay, so here's a little quiz for us. So what is the estimated number of patients who elect to use non-prescription analgesics, so over-the-counter pain medications, that do not read the product labels? So this is they don't read the box. They just see that it's for pain and they just take it. So anyone have a guess?
85.
85. Oh, that's high. Well, it's actually 50. And I don't, this is a little bit older data, but, and I don't know how they really measure this, but 50% is a really big number. So, you know, I have this question here because it just highlights that a lot of people, like, they're in pain and they think like an over-the-counter drug is perfectly safe because it's over-the-counter, they can go and buy it, but that's not always necessarily the case. So it is really important to read the labels and make sure you're aware of what you're taking. So, excuse me. So here's where we can talk about how your pharmacist can help you. So even if your pharmacist seems very, very busy, please do not hesitate asking for their assistance. So if they're not able to help you, they will find someone who can help you. And if they're so busy that they aren't able to talk to you, then you need to find a new pharmacy, in my opinion. So you have a rare disease and there are lots of complications and medications that should be avoided in patients with scleroderma. So it's very important that you have someone who can assist you. So if you feel like you are not getting the attention that you need from your pharmacy, then you should find a pharmacy that's not as busy. You know, some pharmacists might think that that's a bad thing for a pharmacist to say, but I know how complicated and special scleroderma patients are in terms of their medications, and it's really important for you to have access to someone who can help you with your medication. So they can certainly provide you additional information about side effects. They can help you identify whether you're at risk for side effects to a medication. They can review your medication profile to see if you've been on certain medications and that you maybe haven't tried, if one's not working for you. And then they can help you identify combination products and over-the-counter products depending on what's going on. And they should be able to know when to refer you to your provider. The other thing that I'll mention, I think I had this at the end of the presentation, but I'll mention it now, is has anyone, and you might not feel comfortable answering, but has anyone talked to their pharmacist and asked them if they know what scleroderma is? So their community.
This is Jan. Hi, how are you?
Hi, Jan.
Yes, I definitely have multiple conversations with my pharmacist about scleroderma, especially when I'm trying new medication. Yeah.
Okay, good. And did the pharmacist know much about scleroderma when you first talked to them?
No, they've heard of it. You have to really re-educate them in certain ways.
Yeah.
But that's for sure.
Yeah, so one of the things that I always suggest to my patients is to take, so the Scleroderma Foundation has that really nice little booklet of, so if you have access to it, or you can show them the website, either print out or write out the name of the website, and provide them a resource to learn more about the disease. So I used to, before the website had really been updated, I used to recommend that little booklet that the Scleroderma Foundation has. It's like a guide to scleroderma. And I would tell my patients to bring this copy to their pharmacist and ask them to, review it to learn a little bit more about their disease and where there's issues with medications. Now the website's got so much information. So I often tell patients to refer their pharmacist to the Scleroderma website, and they can learn information through that. Even though it's geared towards patients, there's certainly information on there for healthcare providers too. So I think it's all about awareness and their willingness to learn a little bit more about your disease. So thanks for sharing, Jan. I mentioned about pain relief. So sometimes when there is a lot of inflammation, we might have to use corticosteroids or prednisone or methylprednisolone. These are very, very potent anti-inflammatory drugs, so they have lots of complications, though. They are good short term when there's this active state of inflammation, but again, not appropriate for every patient. So that's something that needs to be discussed with the provider. I think I have, so making sure that you're on the lowest effective dose. These drugs can cause a lot of side effects, so being on the lowest effective dose. So how do you find the lowest effective dose? Your physician will help you find that dose, and it's the dose that relieves the inflammation and helps you feeling better. And then you are slowly to reduce the dose and find that balance of the lowest dose that keeps the inflammation at bay and keeps you comfortable. It's important to take it in the morning, because if you take it at nighttime, if it's not the branded Rayos is a branded prednisone, but if it's just regular prednisone or methylprednisolone, it should be administered in the morning to prevent insomnia. Discontinuing therapy as soon as possible. However, that needs to be a conversation with your prescriber. So in patients that are on prednisone, if they've been on it for more than 2 weeks, they should not stop it abruptly. That's very, very important. It should not be stopped abruptly, and it should slowly be tapered off. There are some times when it's used for shorter period of times or lower doses that it can be stopped kind of abruptly if it's kind of within that 2-week window or a very low dose. But that's, again, something that needs to be discussed with the prescriber. So I mentioned that there are a lot of side effects. There are lots of side effects with prednisone when they're used long term. Some of the ones that we're concerned in with scleroderma patients is certainly impaired wound healing if they've got Raynaud's and get ulcers, high blood pressure, fluid retention, gastric and GI or stomach irritation. I think I mentioned all of these things already. Never to stop abruptly, being aware of some of the side effects. Here's just another one. Long term, it can put you at risk for osteoporosis. So if you have to be on prednisone long term, talking to your doctor about osteoporosis prevention. I know that we try to use them very, very, very infrequently because they have been shown to increase the risk of renal crisis. So we don't like to use steroids very frequently in our patients with scleroderma, but again, it's very, very individualized to your specific disease state and your symptoms. Okay, so we're going to talk more about pain management concerns in the GI tract. So as you've already heard me mention that I've talked about how a couple of these different drugs can really affect the GI tract and the stomach and cause more irritation. So the picture over here shows what's a peptic ulcer, which can happen in the stomach, and it can happen as a result of long-term therapy with some of these medications like NSAIDs, ibuprofen, naproxen, and steroids. They can also cause damage to the lining. Might not result in an ulcer, but can cause damage to the lining, and also can increase the reflux that patients have. So we have to be very careful about that. Narcotic pain meds, although definitely need to be used sometimes in patients with scleroderma because they have pain, but it's important to recognize that they decrease the motility in the GI tract. So for some patients with scleroderma, they might be happy for that, but there are quite a few of patients with scleroderma that experience constipation or irregular bowel movements, and changing the motility in the GI tract is likely to make that worse. So it's something that we need to be aware of. One thing that I see in general in practice is that patients will be on pain medications but won't be on a stool softener like Docusate, and that's important. They should generally be prescribed together to prevent severe constipation just in the general population. So if that's a component of your disease, if you have constipation associated with your scleroderma, then a stool softener might be a good option for you. Again, it's very specific to your disease, so that's something that you have to talk to your provider about. Here is a list of medications that we use as antacids or to help lower the acid in the stomach. So we have proton pump inhibitors, which are generally first line, and second line are H2RA or H2 blockers. And this is just, I mean, this is a little too detailed, but this is just showing you that there are cells in the GI, in the stomach, that pump out acid. So in scleroderma patients, these cells are overactive, and they're really pushing out a lot of acid, causing it to go up into the throat and cause damage to the esophagus. So it's important to keep that under control, because if we left reflux and acid hitting the esophagus, chronically, so long term, that there can cause damage to the tissue in the esophagus. It can cause it to get smaller and put you at risk for choking and aspiration into your lungs. So there are lots of reasons why we need to control the acid. They do have some side effects though, which I don't have a slide on that, so I'll just talk briefly about them. It is important that you talk to your doctor about your acid suppression and how big your dose is, how often you're taking it, and long-term proton pump inhibitors have been shown to really decrease absorption of certain nutrients and vitamins like calcium and magnesium. They can affect the absorption of some drugs, so that's something to take into consideration too. Dry mouth, so treatments, things to avoid. So there is often trial and error with patients that have dry mouth associated with their autoimmune disease. Excuse me, I have dry mouth right now from talking so much. So things that you want to try, there's all the Biotin products, the new Moisten. It's very much trial and error. There are some prescription products that are available and at low doses can help increase salivation and increase also tear production. But they can also make you sweat, so it's kind of a balance of finding the right dose. There are some drugs listed here to avoid. Generally, all of these drugs can what we refer to as dry you out. And if the drugs dry you out, then they can worsen your dry mouth. So those are some things that you want to either avoid or try to use in low doses.
Excuse me, Jessica, I have a question. If you could go back to that previous slide.
Sure.
Hi, it's Jan. As far as there's two things on here that I just would like a little bit of explanation. So the psych meds, a lot of doctors prescribe like Prozac and things along that way to try and control stress for Raynaud's attacks. And so I was curious as to long-term effects of those even. Because I don't know if you necessarily call them psych meds, but they are doing serotonin changes in your mind. But I was just curious.
So there are some psych meds, so that's probably not the best term to have on the slide, but so there are some medications that are used for, anxiety, depression that have what we call anticholinergic effects. So not all psych meds have anticholinergic effects, and they have them in various degrees. So the ones that are more common to have anticholinergic effects, which can dry you out, are the ones that are listed on the slide, like Zyprexa and amitriptyline. The class of drugs of amitriptyline is called a tricyclic antidepressant, and it's the way that the drug's mechanism is working is what causes it to have some anticholinergic effects. So it's not all psych meds. So serotonin reuptake inhibitors, generally the doses that we use in scleroderma for Raynaud's tend to be pretty low and have almost no anticholinergic effects. So they shouldn't be having a dramatic effect on like dry mouth specifically, or urinary retention or things like that. Go ahead.
Okay, thank you. The other one was on pain medication. There's a new medication that I've just been aware of that I take. It's called Nucenta.
Yeah.
And I know it's in between like a tramadol and a morphine, nowhere near as strong for morphine, but I guess that would fall, it is an opioid, so would that fall under the Vicodin, Oxycontin form as well?
Yeah, it does, but it does have a role in norepinephrine. So it doesn't really have much serotonin. It affects the norepinephrine transmitter, and it does have some effect on the opioid receptor. But it's very different than, so usually it's dose related. So the higher doses, and when there's like a peak, so like if you were taking, so the Nucenta is more of a, how many times a day do you take it? Just once or twice?
Well, I have 100 milligrams, every 12 hours.
Yeah. So the drugs that are shorter acting, like Vicodin, that's immediate release, those drugs tend to cause more dry mouth because they have like a quicker peak and then they drop off. So if you could see, like I'm motioning with my hands, which you guys can't see me, but so that like when you have a drug that spikes like that, the side effects can be more noticeable and can be more dramatic. So in drugs where that are used like Oxycontin, although like it is extended release, it's a more potent med. Oxycodone immediate release is going to have those spikes, but Oxycontin or the oxycodone extended release, it kind of has more of a even keel of effect, so it doesn't have these spikes. So if you're using low dose, it might not cause dry mouth. With the Nucenta, it does have effects on the opioid receptor, but again, it's not quite as strong as the opioids, and it is doesn't really have those spikes, which is a good thing.
All right, thank you.
Did that answer your question?
Yes, thank you.
Okay. So, touch briefly on small bowel bacterial overgrowth. So this is something, so my husband is a pharmacist also, and when he worked in the community pharmacy, he worked in our town, and there were a couple of my patients that used to go to his pharmacy, and one time he came home and asked me, he's like, oh, so-and-so, I know as your patient, I'm talking to you as a provider to provider because I wasn't sure what to do and the doctor's office was closed. It was evening. He said, why was this patient getting cyclic antibiotics? He was refilling it and there wasn't any refills. Does he have an infection? And I said, no, it's to help keep the bacteria in his GI tract kind of even and not causing problems. So patients that have what we call small bowel bacterial overgrowth it's related to the fact that they have too much of the good bacteria in their GI tract, and it causes a lot of bloating and dysmotility or like motility problems. So it's important to, like, he would have probably given the patient a couple antibiotics to hold them, like a day's worth to hold him over till he could get a hold of the doctor if he had known that what it was being used for. So, and unfortunately, in community pharmacy, when a pharmacist gets a prescription, they don't know what the indication is. So there's nowhere on the prescription in New York State, or any other state for that matter, that where it says the doctor has to write what they're using the medication for. So when the pharmacist gets the prescription, they're kind of guessing almost. I mean, they have an idea of what it's being used for, but you all know that, most of the time they're not thinking it's being used for scleroderma. And we use drugs, we borrow drugs from other disease states to treat the symptoms of scleroderma. So it's important that they are educated on why you're specifically using that medication. So we do use different antibiotics for those reasons. And again, that's something that you kind of have to keep track of your response and seeing, trying to use the least amount as possible, but sometimes it does keep symptoms in the GI tract moving appropriately, or the most comfortably, I guess. There are other drugs that are used that can help with motility. So if the constipation is a major problem, there are a couple of drugs. They come with some high risks, so they need to be used very, very carefully. So I won't go into great detail about that unless someone has questions. But domperidone is a med that I'll mention is not available in the United States. So it's very, very important that the physician and the pharmacist has a conversation, because the pharmacist in the United States will not know that you're on the drug unless you tell them. So but that's very rare. We don't use that in a lot of scenarios. It's definitely a very careful consideration medication. So here are some drugs that can increase and decrease GI motility. So how much you go to the bathroom or how constipated you are. So keeping in mind if you have that aspect of your disease, you know, double checking to see if there's an alternative if it's causing your symptoms to be worse. So any questions about anything mentioned so far? Okay. Difficulty swallowing medication. So this is something that, so Pillglide, I don't know if you can see my arrow here. So Pillglide is something that I came across it at my husband's pharmacy when he was working. I was like there to pick up something and I went and said hi to him, and this Pillglide was sitting on the counter, and it's a spray, and I was like, oh, it is all different flavors, and I asked him if anyone had asked him about it and had used it, and he said, well, yeah, like some people like take it if they have dry mouth, and it really helps them swallow medications. So if you can't find it in the pharmacy, I don't see it sitting out anymore, like when I'm in the pharmacies, but you can order on Amazon. You can ask the pharmacy to order it for you, and it really just lubricates your mouth to help the medication be a little bit more slippery and swallow it a little easier. This is good if it's a big capsule or tablet. You can also ask the pharmacist if you're having trouble swallowing. You can ask them if there's other formulations, or maybe the capsule or tablet size is smaller in a different dose. So maybe you have to take more, maybe you have to take 2 of a lower dose, but the capsules can be, or the tablets could be a lot smaller. So CellCept is a good example of that. The 250 milligram tablets are much smaller than the 500 milligrams. So it does require patients to take 2 at a time, but they're so much smaller, it's much easier for them to swallow. Other thing is to ask the pharmacist if there are other like liquid formulations that are commercially available or that could potentially be compounded or made by the pharmacy to help you with swallowing. Skin thickening and itching. So there are some options for itching, which generally I think moisturizing and topicals are really helpful. There are some immunosuppressants that can help with that. So I'm going to talk briefly about those, but I'm not going to go into great detail. So we have methotrexate, which generally is only used in our scleroderma population when they have kind of overlap conditions and they have a lot of arthritis symptoms. Methotrexate is a complicated drug and can be used very, very safely with close supervision. We tend to not like to use it that much because of the concerns with identifying issues with lung function. So rarely it can cause problems with the lungs, very rarely, but we don't really like to take that risk, or we have to do it very carefully in patients with scleroderma so that we're able to identify if it's the disease or if it's their lungs. CellCept, I think, is probably the most common medication that we use in scleroderma when patients have at any risk of lung involvement. It has been shown to slow the progression of lung disease. I mentioned already about the size of the tablets. Being consistent, taking it at the same time. This one needs to be spaced from the proton pump inhibitor. So if you're on an acid, it's best to take the CellCept first, wait 2 hours, and then take the antacid because it can affect the absorption. Diarrhea is, if the dose is increased too quickly, patients can experience diarrhea.
This is Eva.
Yeah.
This is the first time I'm reading that it affects the liver enzymes, because my liver enzymes were elevated with CellCept and perhaps Myfortic. But every doctor I went to, including the liver doctor, said that CellCept doesn't affect liver. But here you've written that it can affect the liver enzymes. So that's interesting. I must go tell my doctor that.
Yeah, it's definitely, so it's dose related. So if you were on the higher dosing range, and I've seen it in practice, so we've seen patients that have had liver elevations from Myfortic or Cellcept from Cellcept. Usually we use a lot more Cellcept because we can get it easier. Yes, it's metabolized to the liver, and it certainly can cause liver enzyme elevation. So in your specific case, it may not have been related, but it definitely can contribute. So,
okay.
Yeah.
Okay, thank you.
Jessica, this is Jan. If you could go back to the mycophenolate. Okay. So I had an episode where the doctor put me on Cellcept, and I developed extreme GI upset. Yeah. So then he put me on one that was not as invasive to the GI tract. Is that the Myfortic?
Yeah, so if they were able to get that approved, like I would prefer to have everyone on Myfortic. It's tolerated so much better.
Yeah.
The problem that we have is only FDA approved for transplant, so we have a lot of trouble getting it approved by different insurance, and it's more expensive, unfortunately. So that's kind of the limitation. We do try when patients have side effects, but yeah, it definitely is tolerated better.
Okay, thank you.
You're welcome. Okay. I'm not really going to go into cyclophosphamide because this is a very, very big gun medication and really only used if we absolutely have to. So I'm not going to go a lot into that medication, but one of the biggest things is we don't really use it orally that often anymore. We generally use it IV, and we give it as pulse, and that's when there's a lot of blood involvement generally. So we can talk a little bit about, I don't want to go, these medications for pulmonary hypertension are very complicated. So unless anyone has any questions, I can answer them, but I'm not going to go into them in great detail. Renal crisis.
Yeah.
Renal crisis, I think I talked a little bit about this already. Making sure that you are carrying your card, and some providers will use prophylaxis with an ACE or an ARB, so lisinopril and enalapril, losartan. But the studies that support using those is kind of conflicting, so your provider might choose not to treat you with that, especially if you have low blood pressure. Okay, so I think I've really kind of touched on a lot of these things already, but I think that it is important for you to find a pharmacist that is willing to learn about your disease and that has time to talk to you. So that's something that you can, work with your pharmacist or the various pharmacists at the store that you go to, and provide them information about scleroderma so that they can feel more comfortable talking to you about your medications.
So, is Myfortic less effective than Cellcept?
No, I don't think it's less effective. It is actually, it's the active form of Myfortic, and it is not been studied as often as Cellcept has in scleroderma specifically, just because of access. So someone has to fund the studies, or their studies are done with patients that are already on the drug that's covered by their insurance. So, like I said, Cellcept is less expensive, so it's used more regularly because it's on the insurance formularies.
Okay. And you didn't speak about the IVIG, right?
No, I didn't, because in patients with scleroderma, we generally reserve it when they have an overlap condition, in my experience. So we generally use it in patients that have also muscle-related disease, so myositis. It may be, there are some providers who do use it for scleroderma. Did you have a specific question?
No, I just wanted to know what your thoughts were about that and
Yeah.
its effectiveness.
It hasn't really been studied to my knowledge in patients with just scleroderma, and I'm not even sure what aspects of scleroderma it's shown to be helpful with, but in what has been shown is in patients that have overlapped scleroderma and polymyositis or myositis or dermatomyositis. So inflammation of muscles.
Okay, thank you.
You're welcome.
Jessica, there's a question from someone in the audience asking about if you would comment on if being on a specific med over time, the medication can lose its effectiveness. Changing meds.
Yeah. How does that work? Let me stop sharing that. Let's see. So I guess it's very depending on the medication. So there are some medications that patients build tolerance to. For instance, opioids are a good example because they are working on a receptor, and if in the body, if you keep activating or affecting the receptor, the body can it kind of blunts its response. So it adapts to that, and then it requires you to need higher doses and can cause you even to have more pain than you had originally long term. So I guess in that scenario, you can build tolerance. But again, I think it's just very specific to the drug.
Okay. Thank you.
Someone asked about the name of the stool softener. So Docusate, is it Colase? Colase. Yeah, brand name Colase. Sorry, I have my students with me, and they're working in community pharmacy all the time, so sometimes I forget the brand names. But brand name Colase, I can type it here for you. Docusate sodium is the generic. Any other questions? Well, thank you very much. I was happy to give this talk, and I hope that it was helpful.
It was great, Jessica. Thank you so much.
Thank you. Yes, very helpful. Thank you.
Yeah, we'll be saving this recording and uploading it to our YouTube site for playback within a week or so. The next meeting for this Tri-State Connect will be on December the 19th. That'll be the last one for this year. So we hope Jan will be back in the saddle for that event in a couple of months.
Yes, we hope so too.
Okay. All right. And thank you all for joining this conversation. And I look forward to seeing you again soon.
Thank you, guys.
Thank you.